Hi, everyone. Welcome to our lecture series at Monty Hart. Today, we have Michael Albert, who will be speaking about obesity pharmacotherapy, a clinical update. Dr. Albert is a physician board certified in internal medicine and a diplomate of the American Board of Obesity Medicine. He's a clinical assistant professor of medicine at the University of Oklahoma, where he educates on obesity, weight stigma, and obesity treatment. Dr. Albert co-founded a telehealth medical weight management practice called Accomplish Health and currently serves as the chief medical officer of this practice. Additionally, he enjoys educating on the science of obesity on over his 250,000 followers on social media, which of them is myself, who I learn a lot about him and his current posts. So thank you so much for joining us. I'm very excited to have you here.
Yeah, thank you all for having me, and we will jump into it. So we're going to be talking about obesity pharmacotherapy, and I'm going to give a review and sort of update on where we are, hopefully focusing a lot more on the latest developments in this space. Here are my disclosures and our objectives. We are going to understand the what, how, and why of obesity, identify people who may benefit from treatment, describe many of the available treatments, and then be able to then recommend treatments on an individual level based on what we now know. So I want to cover the basics. Obesity at its core is a disorder of excess and dysfunctional adiposity that fundamentally impairs health. And what we know is that there is an inherited potential to develop increased in excess adiposity, that it is fundamentally regulated in the brain. It's greatly influenced by the environment, and it generally is progressive. And the way we've classified obesity historically is using various forms of anthropometric measures, BMI being the one that is widely accepted across major medical organizations. The problem with BMI is it doesn't always tell a very specific story regarding the individual's risk, because as we know, depending upon your sex or depending upon your ethnicity, you may be at a higher risk of health complications than someone else, regardless of your BMI. And so clinical obesity really is much more than just body size, which is really what BMI is a measure of, right? Because when you look at the distribution of body fatness for a given BMI, you can see there's quite a bit of inter-individual variation. So it's super important to keep in mind that you need to take a holistic approach in assessing someone's adiposity-related health risk. Now, how does obesity develop? Fundamentally, we know that it's an energy imbalance that favors an energy surplus over time, and that those contributors to the energy surplus are very complicated. And this gets into the heterogeneity of the disease of obesity. The point here is not to focus on any individual contributor, to understand there are societal levels and individual level factors that are contributing to this energy surplus in that individual. Now, there are a lot of groups that are looking at trying to explain the predominant causes in this, particularly the increases in obesity over the last 50 years. But I would say the debate is still raging. And there is a lot of disagreement in terms of the primary causal factors as it relates to obesity. But energy imbalance is not debatable. That has been validated time and time again. Now, I wanted to highlight this because I think it's a really important study. It illustrates a point that I think a lot of people struggle with, and that is, why can't people just eat less and move more if it's a matter of energy imbalance? Well, this study that looked at the rising prevalences across a range of ethnic groups, a range of demographics, I think really brings home this point that it's not a product of eating too much and not moving a little, because if it was just sheerly a matter of willpower, then we should not see, it would be implausible for us to see that every single group, regardless of how you stratify them, are also suffering from issues of willpower simultaneously. Like, that doesn't make sense. There's more to this story. So let's look at some of the biological aspects. We know that part of the dysregulation in obesity is dysfunction at the level of the homeostatic regulator in the hypothalamus of the brain. The hypothalamus holds many of these homeostatic mechanisms for much of the body: breathing, temperature regulation, thirst, etc. It also does that too for energy balance. And that one of the really insidious aspects of this system, when it becomes dysfunctional, is that deviations away from it, like if you're trying to lose weight, are met with compensatory physiologic adaptations that result in the increase in food intake and a decrease in energy expenditure to restore the balance. So in many ways, obesity is the product of an elevated energy homeostatic state. Let's take a look at some of the evidence. One of the most famous and really the seminal study by Sumithren and colleagues showed this adaptation that occurs. What they did was they had a run-in where everyone lost about 14% of their body weight initially. And what they found is at this run-in, they saw changes in terms of the gastrointestinal peptides that regulate appetite and satiety. And they were changing in a way that would suggest that that individual is starving, that they need to eat more. And those changes persisted throughout the duration of the study. They also correlated directly with increases in the desire to eat and hunger related to that weight-reduced state. And wouldn't you know that over time, people gained the weight back despite the fact that they were participating in an intervention to keep their weight off. There is a physiologic adaptation, an insidious system that continues to support the maintenance of an elevated energy homeostasis. So are there treatments available that can help us address the disease of obesity? Let's talk about treatment. So as we know, historically, we've allowed access to treatment based upon an individual's BMI, which gives some measure of risk related to their excess body size, as well as their weight-related comorbidities. And based upon how severe of disease they have, we have afforded them access to increasing levels of intensive interventions. And it's really important to look on the right side of this as well, because what it tells us is what are the expected weight reductions and ultimately health improvements related to those interventions. I think a lot of people overestimate what lifestyle modifications and nutrition interventions can achieve and underestimate some of these more advanced therapeutics. And I hope we consider that these are not mutually exclusive. These can all be additive because their mechanisms of action work independently and are unique. Now, what we're seeing in my field is a focus primarily on reducing disease burden. So there is this treat to target movement that is happening because at the end of the day, what we're trying to do is improve health and reduce the risk of long-term complications, even if we can't do that for really important outcomes like MACE. But for other outcomes, we know with very good data over the last 30 years that we can dramatically change and alter the course of that disease. And I just highlight this because a lot of people don't realize as little as 5 to 10% weight reduction can make a meaningful difference across a range of adiposity-related complications. How do these drugs work? Well, they have both peripheral and central mechanisms. The older generation drugs like orlistat worked primarily through malabsorption of fat calories. And there are some peripheral mechanisms by which the newer incretin therapies work, but predominantly the drugs work by altering energy homeostasis at the level of the brain. And they do this via different circuits, via the direct appetite circuit and energy circuit within the arcuate nucleus of the hypothalamus, as well as dopaminergic circuits within the mesolimbic system. They also work on other circuits too that we'll talk about later regarding the hindbrain and vagal afferents and the area postrema. But the reality is they're working primarily in the brain. Once again, it is a disease centered in the brain, and that's the evidence we have for a lot of that has to do with how effective these treatments are in controlling disease burden. Now, I'd be remiss if I didn't talk about the issues that have plagued my field, which are around drug development and safety. So I want to highlight that I think a lot of the issue that we have in terms of mass adoption of these therapies is related to a lot of the adverse events that were later found either in post-surveillance or in late-stage clinical trials. We know with the sympathomimetic amines in 1997, Mayo Clinic reported valvular issues, and subsequently there were associated increases in pulmonary arterial hypertension that led the FDA to withdraw the therapy from the market. Rimonabant led to serious severe mental health issues. It never saw the light of day in the US, but ultimately it led to its demise as well. And we know sibutramine famously or infamously led to the increase in major cardiovascular events. So all of these things made the FDA very skeptical, and I think a lot of people in the medical community, skeptical of the role that anti-obesity medications can play in the larger medical therapy armamentarium. In 2012, I want to highlight the FDA revised the guidance and requirements regarding cardiovascular outcome trials, setting them in line and standard to that of diabetes medications moving forward. I do want to highlight this last sort of regrettable case, but lorcaserin was recently, in the last few years, withdrawn from the market due to observational data suggesting an increase in various forms of cancer. So without question, the field has been slowed down in terms of the acceptance and the broad adoption due to these adverse events. What I hope to demonstrate today is that much of the development in the biotechnology hopefully signifies a new era that has arrived, one that is greatly enhanced safety and actually also enhanced efficacy. So let's look at some of those treatments. As you can see, the development of pharmacotherapy has evolved quite dramatically within the last 10 years. And we're going to focus a lot on the newer therapies that I think have rightfully so gained a lot of attention in the incretin therapies. But as you can see, there is a significant jump in the efficacy of these treatments. And I would just draw your attention to the fact that these are placebo-subtracted results based on the clinical trial data. I do want to highlight that tirzepatide is currently not approved for the FDA, but they did get a fast track designation by the FDA and are expected to complete their second phase 3 trial in the next few months. But this is really where the cutting edge of the medical treatment of obesity is headed, into these small peptide molecules or gastrointestinal peptide analogs to treat obesity. I want to highlight that for a long time, we have used off-label prescribing either as individual components of FDA-approved therapies or drugs that are used for other indication that have overlapping pathophysiology with obesity. And we have leveraged these because they are accessible, because in some individual, they can have a tremendous response. We've used these medical therapies up until this point because we really didn't have a lot of effective therapies. I would be remiss if I didn't also highlight that medications we prescribe can have a significant impact on an individual's weight and alter the trajectory of their weight throughout their lifetime. And many of these are drugs that many of you cardiologists prescribe right now. And I want to just highlight the ones that we have good evidence that are more weight neutral than their counterparts. Now let's talk about the story of incretin. Incretins are really fascinating, these small gastrointestinal peptides. And the history behind it is that someone was studying the saliva of the Gila monster. And what they found is that this small molecule protein, exendin-4, which is the structural analog of the human GLP-1, had these really interesting physiologic properties in humans. And ultimately that led to the development, the discovery, and later the approval of exenatide, which was the first FDA-approved GLP-1 therapy in the US. So just a really cool study of how nature sort of led to human discovery and biotechnology development. Now, I want to bring us back to this slide talking about the gut-brain axis, because more and more we're learning there is a strong connection between the hormones produced by the gut and sensed by the brain and the regulation of energy balance, as I highlighted before. We know that many of these gastrointestinal peptides work directly on various aspects of the of energy homeostasis at the level of the brain, including GLP-1, along vagal afferents in the nucleus tractus solitarius, directly in the arcuate nucleus, as well as in the various dopaminergic circuits within the mesolimbic system. So when you think about how are these drugs working, think about the circuits by which they activate and modulate both energy balance as well as subconscious eating behavior and overall satiety. And really, for us to understand where the science has evolved, we need to look at a lot of these really interesting and fascinating studies that were validated as part of this phase 3 protocol for semaglutide for the use in overweight and obesity. Arguably the most famous was the STEP 1 trial, garnered a lot of attention and rightfully showed rightfully so, because it demonstrated about 12.5% placebo-subtracted weight loss between placebo and semaglutide over the course of a little more than a year. I mean, this was a fantastic result. It's the first time we've been able to reliably show in the majority of individuals that you can treat someone's obesity and reduce their weight by greater than 10% on average. What's really cool is they also demonstrated that this effect persists beyond a year and actually at 2 years. And they were able to show that in a majority of cases, people were able to keep at least 5% weight loss off for those 2 years. And I think this is really important as we talk about what's the utility of these therapies. We certainly would like to believe that the health benefits are sustained and the weight reduction is sustained. And we have evidence that that is the case. We also know in a secondary analysis of this study that they show that the appetite changes persist throughout the 2 years, and that people remain with reduced appetite despite being 100 weeks on therapy, which means they're affecting this counter-regulatory response that the body initiates anytime someone tries to sustain reduced weight reduction in prolonged cases. And we look at other outcomes that are meaningful. We saw dramatic improvements in the natural history of people who were dysglycemic at baseline, along with a range of cardiometabolic improvements. So what are the value? Yes, certainly in the treatment and reduction of adiposity, but also a range of cardiometabolic improvements compared to placebo. The next study I want to talk about is the STEP 3 trial. And this was, I think, one of the most fascinating studies as part of this STEP program. What they did was randomize people to semaglutide or placebo, and it was an imbalanced randomization. But what they wanted to determine is how important is lifestyle management for the treatment of obesity versus just the drug therapy? And what is the contribution of these various? So everyone, regardless of placebo, got a run-in of an intensive, well, not a run-in, but they got intensive behavioral therapy throughout the duration of the study. And then they compared the effects of IBT versus IBT plus semaglutide. And the result was astounding. As you would expect, intensive behavioral therapy at about a little more than a year resulted in about 5 or 6% weight reduction, which is what we see. But it didn't add a whole lot on top of medical treatment. In fact, when you break down the contribution, semaglutide's contribution to the overall weight reduction was a majority. It was about 65% contribution to the total weight reduction, showing and demonstrating in a very real way that the physiologic treatment of this disease is the most impactful in terms of the weight reduction. A lot of people ask me, how long do you need to be on these therapies? Can't you just come off when you get to the preferred weight? And we have a lot of evidence, including really good level 1 evidence, to suggest that's not the case. I would implore you to consider obesity as a chronic disease that is progressive and relapsing in nature, much like hypertension and many other chronic diseases. And what they showed, extending the STEP 1 trial that I alluded to earlier, was that people very consistently started to regain weight once they came off the therapy. And so we need to understand this through the lens of a chronic disease, and that people, if they have an adequate and effective response and are improving their health along a range of parameters, they need to be on therapy, just like you would for any other disease, right? If you come off your blood pressure medicine, what would you expect? Or your asthma medication? You would expect the disease burden to come back as the pathophysiology is untreated at that point. And I want to bring this point home because I think this has been missed a lot in the discussions around treatment. The STEP 4 trial was really, really interesting because they basically did a run-in for over 20 weeks of an intensive dietary intervention. People lost a bunch of weight, and then they randomized them to placebo or semaglutide thereafter. What they were able to show is very consistently the placebo arm, despite continuing the lifestyle intervention, started to go back to that energy homeostasis that was already set in their brain, and that the people on semaglutide continued to lose weight regardless. If this is not a powerful demonstration, both of the medical treatment of obesity, as well as how hard people are having to work against the pathophysiology, I don't know what is. A really important insight that I want to highlight here is Daniel Drucker's lab demonstrated when they evaluated the pharmacokinetics and the dosing regimens on the clinical effect and side effects in people with obesity, they saw a really interesting trend. What they saw is there's almost a linear decrease in weight reduction related to the dose of the therapy that someone's achieving. And what they were able to find is that the pharmacokinetics actually predicts the clinical response. It also predicts the side effects and the adverse events. And so there's a lot of really interesting insights right now. I know there are clinical trials looking at 4 and 5 times the dose of currently FDA-approved medical therapies for obesity. Because the reality is, if you can achieve higher plasma concentrations, you are going to saturate the receptors, have a more meaningful clinical effect on the end organs that you're targeting. So I just wanted to bring this home because there's a lot of conversation about, well, this person didn't respond to therapy. I guess this treatment's not going to work. It may in fact be that based on their unique metabolism of the therapy, they need higher doses to achieve sufficient circulating levels of the drug. And I think this is a really important insight that Drucker's lab demonstrated in the last few years. I want to talk about, while it is off-label, and I want to be very clear, it's not FDA approved for the medical treatment of obesity or chronic weight management. I want to highlight, because we're all anticipating that it's going to be approved this year, and that is tirzepatide. What's unique about tirzepatide is that it has a dual action. It agonizes both at the GLP-1 receptor as well as at the GIP receptor. For people that don't know GIP, it's been called gastric inhibitory peptide. It's a nutrient responsive hormone, and what's really cool about this is it's a single molecule that agonizes at both receptors and has a pretty long half-life, which is why it's given typically in once-a-week injections, much like the newer incretin therapies. But what's really fascinating is that it has this imbalanced agonism. It activates GLP-1 with the same affinity as GIP with the same affinity as native GIP, but has a 5-fold lower binding affinity for GLP-1 as native GLP-1. So there's this imbalanced agonism. And the question that a lot of people have is that what gives it its unique properties that we're about to evaluate? So the SURMOUNT-1 study, which randomized people to placebo and tirzepatide over the course of about a year and a half, demonstrated remarkable reductions in body weight and disease control. What's totally fascinating is when you look at the highest dose of tirzepatide at 15 milligrams, nearly 40% of participants lost 25% or more. Just a remarkable achievement in the evolution of biotechnology. And 9 out of 10, more than 9 out of 10, lost at least 5% of their total body weight. And you also compare that to other cardiometabolic factors. As expected, with that level of disease control, you saw an improvement in almost any cardiometabolic factor that you care to measure. I think this waterfall plot, which I love in these weight loss trials, really drives this point home. The area under the curve for tirzepatide compared to placebo is just incomparable, in my opinion. Look at the level of disease control you get with tirzepatide, with really effective therapy, compared to placebo. I think this is just an incredible visual to really drive the point of the medical treatment of obesity. And while these weren't done head-to-head, I want to highlight how do these drugs compare to each other at their respective doses. You can see here 2.4 milligrams of semaglutide is quasi equivalent to about 5 milligrams of tirzepatide. I do want to preview a few treatments that are in development. One of those is cangrelintide, which is a long-acting analog form of amylin. Amylin's co-secreted with insulin from the beta cells. It helps enhance insulin sensitivity. It helps to lower body weight regulation through a reduction in appetite and an enhancement of satiety. And what's interesting is that this long-acting form of amylin was able to outperform liraglutide over the course of 26 weeks in this phase 2 dose-finding study. The other drug that's really interesting in terms of a non-incretin therapy is this drug that's been repurposed. Originally developed to help with myopathies, bimagrumab, which is an activin type 2 receptor inhibitor. The activin type 2 myostatin pathway is involved with catabolism of protein and protein synthesis. And if you inhibit this pathway, you can actually enhance the preservation of skeletal muscle as well as increase the synthesis of it. And what they were able to show in a remarkable phase 2 trial in people with obesity and type 2 diabetes is not only can you lose fat, but you actually can increase skeletal muscle development. when you talk about the holy grail in obesity, it's really about modifying body composition in a favorable manner. Bimagrumab, at least early on, has demonstrated that, which makes it a very compelling potential tool if the safety profile continues to demonstrate good safety. So there's a lot in development, and when you start combining these drugs as they're being evaluated, given the novel mechanisms, combining long-acting amylin with a high-dose incretin therapy, you can start to achieve things like 17% weight reduction at 20 weeks. And when you look at the modeling for these studies, and currently this therapy is in phase 3 trial, the expectation is that it's going to get anywhere between 25 to 30% weight loss at a year that will be sustained. Really, really remarkable changes in evolution in the development of the medical treatment of obesity. Now, where is the field headed? It's headed towards what a colleague of mine has called nutrient-stimulated hormone-based therapies, and it's really just combinations of these small gastrointestinal peptides. And what you can see is there are a number in development. I'm really excited to see what the triagonist that is currently in phase 3 trials will show. It also looks to be very promising. It's made by the same manufacturer as tirzepatide, and we already highlighted the other therapy in phase 3 trial right now. So there is a lot in development. I can tell you the early clinical data is very, very encouraging. I think we will have in the next 10 years a remarkable number of tools to help people that are suffering with a range of cardiometabolic diseases, including obesity. Now, I wanted to highlight a few practical aspects of prescribing anti-obesity therapies for currently FDA-approved drugs. And one of the therapies that has been on the market for a while now is liraglutide. Liraglutide being the first GLP-1 therapy that was FDA-approved for the treatment of obesity. It is FDA approved for the treatment of diabetes under a different brand name, but for obesity, it's prescribed up to a maximum of 3 milligrams under a particular label. And what's really exciting with the GLP-1 therapies in particular is that they did demonstrate superiority in reducing MACE compared to placebo in people with type 2 diabetes. While we don't know if that's true in people without, it does suggest a very safe cardiovascular profile. And as I'm sure you all take care of a number of patients with high risk or established cardiovascular disease or cardiovascular disease equivalents, this is something to consider. And you can look at the side effects, but I would say generally speaking with incretin therapies, the side effects for the vast majority of people are short-lived. Only about 20% of people experience, a mild side effect, and as low as about 4 to 5% will experience such a severe side effect that they have to discontinue therapy. What I would add is my little clinical anecdote. The clinical trials had to follow very rigid titration protocols. And maybe the most practical element that I could convey to you all is follow your patients. If your patient's telling you they're starting to have some of the GI side effects, the most common of which is nausea with incretin therapies, they need to slow down the titration. They need to stay at that level of the dose until their body really adjusts. In doing so, my clinic we've started compiling internal data that our discontinuation rate's less than 1%. So if you don't push the titration at the rate of the clinical trial, many more people will be able to tolerate therapy, and it's much less of an issue. So I think that's a really important translational consideration when prescribing any of these novel incretin therapies. Nobody who's pregnant should be trying to lose weight. That's just something that's important to highlight. Now with semaglutide, once again, its diabetes counterpart demonstrated a reduction in MACE. We believe that these therapies are probably safe for people at higher risk of cardiovascular disease and who have obesity. So once again, the same considerations are made. The difference with semaglutide for obesity is that it is approved up to 2.4 milligrams, whereas type 2 diabetes is only approved up to 2 milligrams. What's interesting is it's the exact same bioactive molecule. So I want to highlight this. There's been a lot of controversy in the media, and maybe many of your patients has brought this to your attention. Oral semaglutide, injectable semaglutide for diabetes, injectable semaglutide for obesity, the same drug, same active ingredient. There is no difference. In essence, these are all valid treatments for both diabetes and obesity, and they're in the interchange between which brand drug you use really is quite meaningless. If someone is responding, these are valid treatments. Semaglutide's FDA approved for both indications. So I just want to highlight that because there has been concern about improper use. Semaglutide in any formulation is the same. It just may be administered via a different route and may be called something differently, but that really doesn't have a whole lot of medical relevance in terms of the clinical treatment. And I do want to mention the SELECT trial is currently finishing their final visits for the participants. The SELECT trial is the cardiovascular outcome trial for semaglutide for obesity, and it's expected to be reported out this year in the fourth quarter. I heard that they're hoping it will be a late-breaking study for AHA come November. So just to put on your radar, that's something that's really exciting. And we're all waiting with bated breath to have really good level 1 evidence for MACE reduction in the treatment of obesity. It would be the first, regardless of the treatment, to demonstrate MACE reduction, whether it's bariatric surgery or the pharmacotherapy. So it would be a big deal, certainly in my line of work, in increasing our confidence in the safety as well as the efficacy of these treatments for really important hard outcomes. I want to highlight another therapy, and you'll understand why. Phentermine and topiramate extended release has been around a long time, and it's a combination of an anti-epileptic therapy that works via a number of different and kind of unknown mechanisms, but it modulates GABA activity and different voltage gated channels, which our evidence suggests that really attenuates a lot of the mesolimbic activity in obesity, as well as appetite. Phentermine, a sympathomimetic amine, works by increasing norepinephrine, dopamine at various neurocircuits in the brain. The combination of these has been shown to reduce appetite, to reduce, at least through observation, things like carb craving, food-seeking behavior. And for a long time, this was the most effective therapy we had in obesity, really up until the latest semaglutide iteration. It does come with a little bit more consideration around some of the side effects. You definitely need to ask people if they have a history of glaucoma. You need to ask people you need to make sure their blood pressure is controlled. I generally avoid this therapy in people with high risk or active cardiovascular disease, and they need to be aware of sort of some of the contraindications related to the therapy. But I will tell you, if any of those considerations aren't relevant, it's a very effective treatment. I've had people absolutely have incredible responses just because of the nature of the drugs. You need to make sure that people, and it's recommended, if it is a woman of childbearing age, that she be on some form of reliable contraception, if not 2 forms of reliable contraception. And if the man had a vasectomy, that also counts. So the benefit of phentermine topiramate, as I'll highlight a little bit later, is it's very accessible. You can prescribe it in its generic components, or you can prescribe the brand therapy, which is less than $100 a month through the specialty pharmacy of the manufacturer. So it's very accessible, and we'll talk about that, the relevance of that, when we talk about how do people get effective treatments in their hands. But I did want to highlight the cardiovascular outcome data regarding obesity therapies. And the short of it is this: we do not have any evidence for any cardiovascular outcome trial that's been powered to demonstrate superiority versus placebo, that there is a difference, that we can reject the null in that case. We have no evidence, and in fact, most of the trials have never been completed. The AQ claim trial, which was supposed to investigate the MACE reduction in people taking phentermine topiramate, never actually was completed. The naltrexone bupropion extended release trial was ended early due to futility, and in terms of the incretins, much of them have been grandfathered in given their data with diabetes, but we need to really prove that there's level 1 evidence in people without diabetes that these treatments can work, because I think that will be a really important measure for the next phase of adoption and uptake in these therapies as part of, once again, the broad medical treatment of people with chronic disease. So I do want to highlight that there is no CVOT that has demonstrated superiority of any experimental agent versus placebo for people with obesity and without diabetes. I told you I would talk about cost, and I think this is very relevant. If you're a physician, you deal with cost every day. And what I want to highlight is a review study published by the Institute of Clinical and Economic Review, ICER, that came out last year. And basically what they demonstrated is that semaglutide, despite it being the most effective treatment we have available that's FDA approved, the current list price of the drug that is annualized is not cost effective. In fact, it would require about a 40 to 50% reduction in the list price of the drug before it would even start to be within the range of the typical thresholds of willingness to pay. And I think that's really important as we talk about equity, as we talk about the justice in the delivery of treatment, that cost is a major issue. And when we need to look at therapies that might be in fact cost effective, phentermine topiramate, while not as effective, and maybe doesn't have quite the safety profile as semaglutide, is much more cost effective. It actually exceeds many of the thresholds, or it's below many of the thresholds that are typical in terms of willingness to pay. It is very affordable when you compare it to alternatives within the space. And so this is something we have to consider when we are utilizing evidence-based treatment, regardless of whether we want to. This is the reality we deal with in the modern US healthcare system. So I want to just review some of the things we talked about, whether it's the nature of the disease of obesity being a disorder of excess and dysfunctional adiposity, that it is regulated within the brain, it is greatly influenced by our modern environment, and is generally progressive. So letting people wallow on their, in their own devices trying to self-regulate is a failing proposition. We have about 30 years of data to suggest that people aren't going to, on average, meaningfully reverse their disease with their own efforts. We need to be playing a greater role as a medical community in providing effective medical therapies. And I hope this starts a lot of that discussion. There are particular commonly accepted thresholds by which we would consider people for medical treatment. But I would also like to highlight that you should not become so myopic and focused on BMI because it's imprecise at the level of the individual. And we need to know how also sex and ethnic differences influence one's health risk related to their excess adiposity, that there are other measures like waist circumference that can give us additional refinement of risk and help us to better stratify one's individual risk. That medical treatment, as compared to placebo and lifestyle interventions, helps make people healthier. It does. We have level 1 evidence that lifestyle interventions plus medical therapy is more effective in the majority of patients than lifestyle therapy alone. And that when you look at the advancements in the biotechnology around this space, it's really around nutrient-stimulated hormone-based therapies. And what you will see are combination therapies that continue to move the needle in terms of the level of disease control and health improvement that people are able to achieve over the long term. We do need to study. We need to make sure that really important, meaningful long-term outcomes are proven, that we can show that this is a worthy pursuit before there is broad financial investment, because we need to show that it's going to enhance the health of people's lives, like reduction in MACE and important measures. But I am a big proponent of looking at measures just beyond MACE and beyond all-cause mortality. I think prevention of diabetes is relevant. I think physical functioning is relevant because we want people to be able to live their lives meaningfully and contribute to society. And when we talk about drug therapy, we have to talk about cost. We cannot just look at what is the latest and greatest. We need to look at what is accessible, what is just, what is equitable. And so we have to pay attention to the cost-effective nature of the therapies we're prescribing and be aware of how that will impact our patients in the long term. Because as I already demonstrated to you, the paradigm is long-term treatment. If someone is seeking treatment for obesity, it is a long-term investment because obesity is a chronic and relapsing disorder. Thank you.
Thank you so much. What a wonderful lecture and such an important topic. As we were discussing before we started, when I was training in medicine and cardiology, I never had this lecture. So I'm happy and excited that you brought this data to our fellows and to everyone that is watching. Please put your questions in the QA and we'll go through them. I think it's very important that the practical points that you gave us. Not everyone can reach such a high specialist like you, so it's important that everyone gets comfortable with this. I'll start with the first question before we go to people's questions. What about the body composition with the GLP-1 agonists, and how do you combine that with exercise, maybe hopefully targeting that?
Yeah, I didn't show. Great question, by the way, and I think this is a hot topic right now. So the first contextual element there is any intervention that significantly reduces adiposity will come with a loss of lean mass. We know this to be true. Now, there is no evidence that GLP-1s preferentially lose more lean mass tissue than any other intervention that produces significant weight reduction. But what we tell with everyone, and I think a really good study I didn't highlight here, if you want to look up, it's in the New England Journal of Medicine, I believe, Lundgren et al. 2021, off the top of my head, they looked at this. They looked at exercise plus liraglutide versus exercise alone, or liraglutide alone, or a lifestyle intervention alone. And what they showed is after they had a run-in period of about 14% weight reduction, what happens when you randomize people to these various interventions? Exercise plus liraglutide resulted in even more fat loss after the run-in period and actually lean mass gain. And when you just had the exercise group, they preserved their lean mass but didn't have substantial fat mass loss after the run-in period. So I think we need to think about all of this as a comprehensive package, right? Exercise is critically important to provide those anabolic signals such that the lean tissues and the organ systems understand that we need to retain skeletal muscle and we need to retain bone. And that is critically important, as we know, based on long-term data towards health and longevity.
Thank you. That's a great response. Also, I think it's very hard for people to exercise when they are extremely overweight and with morbid obesity for their joints. So I think probably helps them with that too. So we have one comment from an anonymous attendee. Liraglutide will be generic this year in the fourth quarter. Going to the price, hopefully we'll see a decrease in price. I guess it depends on multiple factors whether that happens or not. But a comment from our chief of cardiology, Dr. Mario Garcia. Can you comment on the usage of SSRI and association with obesity?
Yeah, I mean, I think more so with antipsychotics, but certainly with some antidepressants, there is an association with weight gain. And I didn't include it in the sort of weight gain slide, but the majority do have an association. And so when we talk to patients, it's important to provide them that insight. What I tell patients, I have many of whom are very well controlled on their antipsychotic or antidepressant therapy. That's another important health outcome, right? And we may just have to appreciate that that is a potential side effect for you and understand that that may influence how aggressive we are in managing your obesity, because it is something we are undoubtedly working against. So the majority of SSRIs do have some associated weight gain. Bupropion really being the only one that consistently and reliably not only demonstrates weight neutral, but also weight reduction. Once again, it's part of an FDA-approved combination therapy.
Thank you. And Dr. Garcia also asked, any concerns about a potential risk for valvular disease with phentermine?
Yeah, I mean, this is a really good question. So when they looked at the studies, they found that exposure was the most predictive element for fenfluramine and dexfenfluramine-induced valvulopathy. We have observational data, particularly out of Korea, of people on phentermine continuously for 2 years that did not have any signal for harm. But I say this, I think the FDA is spooked because of the history that I just took you through. They still will only approve phentermine for less than 3 months. So it's only approved for the short-term treatment of obesity. And some of that may be due to the concern regarding this long-term exposure and some of the unknowns. Once again, phentermine topiramate extended release has been taken long-term by many individuals, and there has been no follow-up concern. But I mean, it's always something that we have in the back of our mind, given the related nature and the chemical structures between phentermine and fenfluramine. They're not identical, but they're related.
Thank you. Dr. Garcia, do you want to ask a question, or you want to? I think you're muted. Yeah.
No, thank you so much for such a wonderful presentation. I actually had those two questions, which boggled my mind, but you know, clearly, yeah, there's a competitive, I think, factor in society right now between anxiety, depression, and obesity, because I think I bring the question about SSRI because, a lot of patients that suffer from obesity are patients who had anxiety and depression. They look at food as a way to relieve their symptoms. And that's why it's concerning. And sometimes you are in that dilemma. Do you start the SSRI or not? And what will be the impact?
Yeah, I think that's a great point. When you look at the data, there's a bidirectional relationship. So obesity can in and of itself increase the risk for depression and anxiety, and incident depression and anxiety can increase your risk of weight gain and obesity. So, I've definitely seen the case on an individual level where the treatment of their depression actually resolved a lot of the issues that were causative in their weight gain. And I've seen people lose weight. I've also seen it the opposite, where the treatment actually resulted in further weight gain. So this is where we cannot take broad strokes in our approach to managing an individual. We really need to personalize the approach and factor in all these considerations. And sometimes it means changing. And this is a lot of my practice. I reconcile medications prescribed by other providers and try to put people in collaboration with their other providers on treatments that are more weight neutral or weight favorable. And so this is part of the art of medicine, I would say. And I think, Mario, you're exactly right that there is this sort of complex relationship. I think that slide that I demonstrated, how does this web work? Well, it's really complicated, and you just used one example, and there are so many others where these things are intimately connected. Absolutely.
Thank you. We have a question from Minashki Budara. Any data on changes in the microbiome?
Yeah, so I just went to a presentation at the Royal Society. I attended it virtually, and one of my friends, Matthew Dalby, presented a review of basically all the evidence. We don't know the significance of the relationship between the gut microbiome and obesity right now. All the data is preclinical. The human data really hasn't translated. And so anyone that is suggesting you can manipulate the gut microbiome to change the pathophysiology is not based on any direct evidence. So I would say more study. I think there's something there. How does the causal relationship work? What is the clinical effect size of that relationship and sort of determining the presence or absence of disease? We don't know. And so I think, once again, it's all based on preclinical data. We don't really have reliable human data at this point to suggest that's a meaningful target.
Dr. Garcia, you have a comment?
Yeah, I had another thing that comes to mind now. Certainly, have you, obviously, I assume we continue to recommend different diets. Have you noticed that any particular dietary approach works better with drugs like semaglutide or liraglutide? Are there any diets that you would avoid?
That's really interesting. Short answer is no. So when you look at the studies, there's a lot of evidence to suggest that in some cases, these therapies lower the energy homeostatic point, but they don't necessarily change the way that brain functions on some level. And what I mean by that, and the relevance of this, is a lot of people reduce their total caloric consumption in a day. They don't necessarily change the foods they're eating. And there was a really interesting study, not for pharmacotherapy, but bariatric surgery, that was published by Carol LaRue's group out of Europe, that showed the quality of the diet actually didn't improve. It was just it was the volume of food that was being consumed, the total energy in the diet, that reduced and stayed reduced after bariatric surgery. So, my diet advice is very bland, and that's because it's based in the evidence, is that there's really no evidence to support diet superiority in obesity. It's really an individual level consideration, and any diet that allows someone to eat less and it's enjoyable for them. And I think the enjoyable thing is we don't give enough credit to, because that has so much bearing on their ability to sustain it. I think is probably the most relevant diet to them. In my practice, we do use medical nutrition therapy for some disease-specific states, high-risk cardiovascular disease, looking at Mediterranean diet and the like, or people with type 2 diabetes looking at carb-restricted diets, a potentially ketogenic diet, and total meal replacement, which I have the best data. But that's really specific to the disease and not necessarily obesity per se.
Thank you. Obviously, the question for intermittent fasting or time-restricted eating will come here. I know it's controversial, but any thoughts on that?
Yeah, so I think the meta-analysis that came out last year showed late time restricted eating, which is how most people engage with it, 16/8, where you fast all the way until noon, and then you eat between an 8-hour window from noon to 8. That is no better than just continuous energy restriction, which is how most people diet. Where time restricted eating can be particularly physiologically aligned is when it's eaten in a way that's respecting our circadian rhythm. So early time restricted feedings, where people actually stop eating in the early afternoon and they eat when they first wake up. So your feeding window is early morning to early afternoon. Those have actually shown enhancements in cardiometabolic measures, improvements in insulin sensitivity, reductions in visceral adiposity, and the like. And I think it has to do more with circadian rhythm and becoming more aligned with our circadian rhythm than it does the nature of intermittent fasting per se.
Thank you. Very interesting. We have a question from Rob Oswald. Do you see targeted therapies to help direct people to more healthful diets? In example, reduce cravings for junk food.
Yeah, I mean, I think to the extent that people have a lot of poor eating behavior from these sort of the subconscious liking and wanting phenomena that we described, that's part of this very dysfunctional mesolimbic system. It appears that the incretin therapies do blunt some of that activity. And I can only tell you anecdotally, because we don't have direct evidence yet, that many of my patients do report no longer suffering from cravings, feeling like they are in control. And so working with them on dietary changes seems a lot more reasonable and achievable from their perspective. They often come back saying, I don't have that late night craving like I used to, or I feel like I need to binge eat on X, Y, or Z. I'm focusing on increasing my fiber and my protein, reducing my saturated fat and the like. And so, at least anecdotally, I would say it seems to help, but I don't have direct evidence of that. So, I heavily caveated, I would say.
At least many of my patients have said that also helps them to drink less. I don't know if you see
Oh,
that.
yeah. That's I think that is a really remarkable side effect. And there's been some attention brought to this, and I think it's actually being studied now, but reduction in a lot of alcohol, potentially other forms of drug abuse as well. And that's because there's a lot of overlapping neurophysiology related to these problematic behaviors. So I think it'll be really interesting to see if there are expanded indications of these incretin therapies, because they affect some of these circuits that have been historically hard to target with legacy medication.
Thank you. And we have two questions from our fellows. One, and I know one of our fellows has published on this. He's asking, we'd be interested in seeing if these medications, how they work in heart failure patients and the relationship of GLP-1 agonists and heart failure. Any comments on that?
Well, they're currently investigating in HFpEF, which is typically more of an adiposity associated form of heart failure. HFrEF, we don't know per se. SGLT2s, which is sort of the closest new drug, has more data. Is it possible, physiologically? I mean, preclinical data suggests it enhances endothelial function and reduces inflammation. And can that have a meaningful impact on disease substrate? Possibly. It needs to be studied, right? Like I'm sitting here speculating. I don't have any direct human evidence. So, I think there is a hypothesis that you can convince me of if you look at the rodent studies and the preclinical studies. I also think what's very compelling from the observational data is a reduction in incidence of in-trial Alzheimer's disease. So when they aggregated all of that, and we believe that is also very much related to cardiovascular dysfunction and metabolic dysfunction over time. So there are a bunch of these really exciting potential use cases. We need good evidence. We need to directly study it. And so you're going to get me really excited. I'll talk about all the speculation, autoimmune disease. There's a whole lot that I think we're excited about. NASH, NAFLD. We need to study it. That's the fundamental thing.
We need data. Yeah, I agree. And the last question from our fellows, we have a huge epidemic in obesity in the young people, in children and young adults. Are these medications safe long-term? Do you foresee people being in these medications for life? Or what's your idea on this?
Obesity is a chronic disease. It requires long-term treatment, and we have no evidence at this time that you can convince the biology to lower the homeostatic point indefinitely, that it requires therapy to continue to reduce that point. And I think I provided some evidence for why we believe that to be the case. So yes, I believe it needs to be long-term. It doesn't have to be the same drug. I always tell my patients, if there's a newer, better, safer medication, why not consider that? But we need to think about this as we do any other chronic disease paradigm. With that said, do I think the recently FDA approved therapies are safe in children? I think all the evidence suggests that incretins right now are safe long-term. We've had them available we have 17 years of human data, many millions person years of exposure. There have been no signals for harm really from the in-trial data. From observational data, maybe a slight increased risk in thyroid cancer, which is part of sort of the warning. But of the in-trial data, there has been no concern for an increase in thyroid cancer or medullary thyroid cancer. So these need to be studied, but I think decades of data demonstrating safety, and if anything, improvements in health. So that's the other perspective. When we talk about risk benefit, what is the harm of us doing nothing, right? I think oftentimes we don't frame it from that perspective. Obesity directly contributes to cancer development, heart disease, kidney failure, liver failure, all of these different organs it touches on. And us doing nothing, as many researchers have suggested, we're increasing someone's obesity years exposure, or BMI years, as been described in the literature. And this is, I would analogize it to lipid years, as many of you all are very familiar with. Obesity years is the exact same phenomenon. And as you increase the area under the curve, you're increasing one's risk. So doing nothing is also not an option, in my opinion. So I think we have to view it in its entirety and find treatments that work both on an individual level and at a societal level, because it's not enough to have good treatments for individuals. We need to prevent disease incidents for the future.
Thank you very much for the great lecture, and hopefully we'll see you soon in AHA or another conference.